أول شيء اللي عم بيقدموا الفحص هالسنة إنه تحفظوه عن الغايب.
ايوه
بس ليك
وانا
في
بدي بس اتكلم.
كثير حكي بالباك جراوند.
اوكي
إذا بيقدروا يسكتوا بكون ممنون. عم
اكيد
بسمع كل
اكيد.
الحكي هون. اليوم رح نحكي عن الجنراليتيز. وشو هن الجنراليتيز؟ we will start one after the other, starting with the generalities, then go into the proximal humerus fracture, forearm fracture. I'm sure Dr. Khalid knows more than I on the fractures. ما عم نسمع. ما عم بسمع. Because everyday basis. But I am giving you the sequence of fractures that we often ask in the Arab board exam. And so as to have an idea of what to study and what not to study. Okay, so I want you to realize this. هيدي الأسود ما عم بدي أشيلها. انشيلت. We'll start with the proximal humerus, following the generalities. Let us go and start. When you get a fracture, it's very important, and these questions we routinely ask. You should make sure that the airway is open, it's maintained, and you should be careful about the cervical spine, especially at the. I love to ask that question. Which portion of the cervical spine is difficult to be seen? You should pay attention to whether the patient is breathing. You should study the level of his circulation level in the body. How much blood did he lose? You estimate it. And by this, you decide whether you should give him isotonic solutions or whole blood, namely resuscitation, hemodynamic stability, blood loss of 1,500 cc's or 30% of the blood volume results in hypotension, tachycardia, and decreased urine output. The mean arterial pressure in these multi-trauma patients should be more than 60. If it's below, it's bad. The heart rate should be less than 100. The urinary output should be 0.5 to 1.0 millimeters per kilogram per hour. And you should follow the lactic acid levels. As I mentioned before, you start with crystalloid isotonic solutions. If you find that this is not supporting the patient enough, you then give O negative blood, and once you're able to type the blood, you give him the properly cross-matched blood. For an AP X-ray of the chest. Look at the mediastinum. Look at the mediastinum. If there is widening, it tells you that there's something going on. There is hemorrhage. So you should be careful and alert. Look at the chest if he has pneumothorax. Take a lateral cervical spine of the level which is most important. Nowadays, we're asking for CT scans. An anterior posterior view of the pelvis and the proximal femur should be taken. What about open fractures? You should do an aggressive irrigation and drainage. In the meantime, you should do a temporary fracture stabilization and start the patient on intravenous antibiotics. Don't forget, and do a repeated stage of irrigation and drainage until the soft tissue is ready for coverage. That this classification is by Gastillo, and a grade 1 is where the length of the lesion is less than 1 centimeter. Is greater than 10 centimeters. They later added grade 3 into 3 parts. The A is adequate tissue focus, and in B, extensive periosseous stripping is present. You can approximate, but you would need soft tissue coverage. Then last, which is the worst, is the vascular, is the Gastillo classification. You have, we give it for 48 hours following each procedure. Khalid, am I clear? خالد
واضح جدا يا حضرتك. تمام.
عم تسمعوني؟
واضح جدا واضح جدا.
خالد, am I clear?
تسمعني
الو
دكتور؟ الو
عم تسمعوني؟
ايوه
عم تسمعوني؟
يس.
اوكي يلا رح كمل. Pulmonary complications. One of the first pulmonary complications that is the fat embolism syndrome. This can occur in isolated long bone fractures. This occurs at a rate of 0.% Then it becomes more common whenever you have a polytrauma patient. 4 to 48 hours. بيجينا اوقات resident بيقول لي في بتيكي, when did the injury occur? 1 hour ago, 2 hours ago. At around 24 to 48 hours following injury is the timing to occur. Inflammatory response is embolizes throughout the system. It produces an inflammatory management. What are the diagnostic criteria؟ وهيدي اللي بشدد عليها. You look at the PaO2, it's less than 60. They have central nervous system depression. You see that the patient becomes completely depressed. If you look at the chest from the front, you see that there is petechial rash, and they have pulmonary edema. Minor diagnostic points include tachycardia, the patient has fever, they have small emboli in the retina, fat in the urine or sputum, thrombocytopenia, and decreased hematocrit. Additional studies, you will find that the PCO2 rises. It's more than 55, and the pH drops below 7.3, and you see that the respiratory rate is rapid. These patients have dyspnea, they have tachycardia and anxiety. What about adult respiratory distress syndrome? Some investigators say that at times the fat changes into an adult respiratory distress syndrome. But I don't want you to put this in your mind. You have to keep it in a corner if somebody asks you. But an adult respiratory distress syndrome is far more serious than fat embolism. You have refractory with poor gas exchange. And these patients have late sepsis, they have a multi-system organ failure, and a high rate of mortality. The thromboembolic complications do occur. And for this reason, you have to make a plan such that you treat the patient and mobilize early. In addition, we use mechanical devices. We put filters. Compartment syndrome. You have to have a high index of suspicion, and you should have a low tolerance to do a fasciotomy if you suspect it. And you have to know the 5 P's. But of the 5, important, pain out of proportion. Patient with a fractured tibia, when you splint them, the pain should decrease. He has a compartment syndrome, he will be screaming and saying, I'm having pain. In addition, if you stretch a muscle with a patient who has compartment syndrome, he will want to kill you. He will have. They also have paresthesias, pale. طلعوا هول ال5 P's بدكم تحفظوهم. You should know them by heart. And this is the part of one or something very important, like equivalent to it. We have to know the 5 P's. These are very important to memorize because these are simple questions we ask the candidate. Please, please, these are important. The clinical diagnosis is direct measurement of compartment pressure. Now, what I follow, I measure the tissue pressure of the suspected area. I go around 5 centimeters, within 5 centimeters distance from the fracture site. I have a striker, which consists of, and I record. If it is 30 millimeters or more, this is a sign that this patient has a compartment syndrome, and edges. I first remove the cotton, I remove the cast, I observe no improvement, then I go for a fasciotomy. In addition, you should record the diastolic pressure, and if the tissue pressure is within the last 20 minutes, it will tell you that you should do a compartment release. Spinal cord injuries. You should look and level the degree, the area of injury. The most caudal spinal level with normal motor and sensory function on both sides of the body. Yeah, when you have an injury, the lowest level of injury where you don't have any function below it is the spinal cord injury, the level. Of course, you should know about incomplete injuries. You should know about the anterior cord syndrome, the posterior cord syndrome, the central cord syndrome, and the Brown-Séquard syndrome. I will not be going through this because we gave it to you on a spine lecture. You should know how to examine the patient. You should see whether the patient has any sacral sparing. You should do the bulbocavernous reflex. The bulbocavernous is by putting your finger in the anus and squeezing the penis. If it's kinking or contraction or spasm, and this usually is over in around 12 hours and at most 24 hours. I want you to quote it in the exam because many of the examiners don't